Hi all, this is Kate Armbruster and this is my shift report assignment video. Today I will go ahead and discuss shift reports that are common in the OR setting. Shift report is a little bit different when compared to reports given on a med-surg or a telefloor, so I just wanted to be sure to go over those reports and discuss what kind of reports can be found in the OR setting before I give my mock shift report. In the pre-op setting, we are sure to interview the patient. Be sure that the patient has already been interviewed and has discussed the procedure with the surgeon or surgeons, as well as the anesthesiologist, before we bring them back into the OR. Once we are in the OR, 3 different types of reports are given, and these are called surgical timeouts. There is a pre-induction or anesthesia timeout, which is done with the anesthesiologist as well as the patient while they're still awake. We go ahead and identify the patient. We do 2 identifications, which are primarily the wristband, such as first and last name, as well as medical record number. And then we go ahead and identify certain documents, such as consent has been signed, H&P has been updated and signed, as well as any anesthesia or surgical notes. Then we are sure to identify the site, that there are correct markings on the body where the surgical procedure will be occurring. And then we are sure to identify any patient drug allergies, any antibiotics that the patient has been given or will be given throughout the surgery, and how much of that antibiotic. And then we want to do a fire risk assessment as well. So after the patient is put asleep and before the procedure begins, we do a second timeout, which is a pre-procedure timeout or surgical timeout with our surgeons, as well as the whole staff in the room. So this is where staff, everybody stops doing everything, everybody's silent because they must listen to the circulating nurse as she reiterates this information before we begin the procedure. So this is just to identify correct patient, correct procedure, correct site, correct implants if available. Sometimes patients need mesh implants or other types of implants during the procedure, as well as ask the staff, ask everybody in the room if anybody has any questions or concerns. After the procedure is performed, a 3rd surgical timeout is completed, which is the post-procedure or debrief surgical timeout. The circulating nurse will be sure to discuss what went well, what could have done better, the name of the procedure, and the post-op diagnosis, as well as the wound class and any specimens that have been taken during the procedure. And this is all done in regards to patient safety, especially before we transfer them from the OR to the PACU or to the ICU. So another type of shift report that is done and that I will be doing in my shift report video today is a shift report when we transfer our patient from the OR setting into the PACU. So while multiple PACU nurses are working on the patient, working on setting them up, getting them up on the monitors, there will be one primary nurse that the anesthesiologist, as well as the circulating nurse, will reiterate important information to the nurse before we head out of the PACU and back into the OR to set up for another case. This is patient John Doe, a 70-year-old male, MRN number 123456. Surgeons today were Dr. Smith and Dr. Johnson, anesthesia Dr. Williams. Surgical procedure performed was a Da Vinci robotic-assisted partial right nephrectomy, as well as a laparoscopic right hernia repair with a mesh insertion, and a cholecystectomy performed under general anesthesia. Medical history: patient has a history of being an everyday smoker, diabetes mellitus type 2, hypertension, osteoarthritis, as well as a history of anxiety. Surgical history: patient has previously had a right knee replacement, appendectomy, as well as a vasectomy. Allergies include the NSAID, aspirin, sulfonamide, sulfa drugs, dust, and patient does have some irritant contact dermatitis to adhesive tape, so please use paper tape or surgical foam tape as recommended. Meds given today: the antibiotic cefazolin, 2 grams were given at 8:30 and again at 12:30 for a total of 4 grams to be given every 4 hours. Marcaine 0.25% of local anesthetic was also given twice throughout the procedure for 8 milliliters total of the bupivacaine anesthetic. Patient is currently awake and drowsy. He was very confused and anxious upon waking up, was trying to move arms and legs and get up, and did complain of pain all over, but still has yet to identify the source or localize that pain or describe more of the pain. Due to this, anesthesia has gone ahead and pushed lorazepam 1 milligram for anxiety in the OR, as well as 25 micrograms of fentanyl given for opioid analgesic. Anesthesia will continue to monitor and PACU and recovery. Patient is somewhat listening to verbal commands, but is still drowsy and confused. A 16 French Foley indwelling catheter with a 10 cc balloon was inserted shortly before the surgery at around 8:45 this morning. There is a urinary output of 115 milliliters that needs to be recorded. A Blake drain has also been inserted in the right side upon closure of the surgical procedure. Patient has been NPO since last night around 10 p.m. H&H within normal range. Lab values and blood draws were checked before procedure and are within normal range as well. Blood glucose was tested at 105 before surgery. There are now 4 1-centimeter incisions located on the abdomen and the lateral right side. Skin effects and sutures were used to close, as well as sew in the Blake drain on the right side. There were no intraoperative complications. Patient has been typed and screened for blood. Contacted pharmacy shortly before procedure to have 2 units of blood available if needed. No units were used or hung during surgery, but blood is still currently in the refrigerator if needed. 7 tissue samples were also collected and sent to pathology. Wife is currently waiting in the waiting area. Are there any questions or concerns?